I really thank you all for staying so long. I know I had an 8 o'clock meeting this morning, and it's a long day for all of us. I can really start to talk, and I
have the PowerPoint presentation printed, by the way.
My name's Leslee Shaw. I'm from Atlanta, not that far away, short flight over here. And I guess when you start to think about screening, and you start to think about imaging, or you start to think about laboratory tests, one of the factors that comes to mind is how can we truly integrate this into medical practice. And then the issues start to get discussed about can this be a reimbursable test, and then we start to talk about the public policy debate of screening. What's interesting, if you think about the public policy debate of screening, it really brings into mind a lot of the other tests that we screen for, cancer screening, for example. Now, the value in cancer screening, breast cancer screening, lung cancer screening, any kind of cancer screening, is that early detection leads to improved outcomes. Early detection leads to improved outcomes. And late detection is associated with very costly and worsening outcomes. And therefore, if we have a test, a pretty good test, because many of the screening tests, like mammography, for example, are not that great screening tools. But if we have a relatively inexpensive test, then if it's applied on a population-based level, then it can be what we consider to be not only clinically effective, but also cost-effective. And does that paradigm also fit cardiovascular disease, our #1 killer? Absolutely. So we already have a good paradigm in cancer screening. So applying that kind of rationale to cardiovascular screening, which has been applied, I know Alan and I both were involved in the Bethesda conference, Alan being the chair of that. I was involved with the area of cost effectiveness. One more time, and then, sorry. And so when we start to think about where we are in cardiovascular disease, we have to think of our current state of our healthcare system and the economics of cardiovascular disease, the economics of healthcare. About 50% of our healthcare costs are for end-stage or hospital care. The average yearly health expenditure for an end-stage care is about 5-fold higher than non-end-stage care, and this is from CMS, so this is from a little bit older population, or Center for Medicare and Medicaid Services. There's well-established evidence if we shift care to the outpatient sector, it's going to reduce costs. There are some concerns about driving up the prescription drug cost if you think about screening a population. Although I think prescription drug costs are rising, most of that's due to rising costs, not to do with rising utilization. So if we think about the potentials from a 30,000-foot level, we think about shifting care within our limited resource budget. There's a potential if we could kind of move some of those costs in end-stage care, move some of those costs in hospital-based care and shift them to a screening program. One can see how I think the societal burden of this is very easy to envision. Cost effectiveness comes to mind. The government, all of us make cost-effective decisions in our own lives, hopefully. And a cost effectiveness is by definition looking, it's a simple calculation, looking at the differences in cost. Does anybody have a pointer or no? The differences in cost divided by the life years saved. And this is going to be a problem when it comes to screening, because the full gamut, and when we talk about what the U.S. Public Health Service has defined cost per life year saved, we don't always use tests to save lives. We don't always use, perhaps we also want to avert a heart attack, i.e. the name of the organization, and therefore some of these standards may not apply. But the general standard is about $50,000 per life year saved, and we have an advantage. We can actually get a very low-cost item, but it's not that effective, and we can still find some value in it. Of course, when it has associated with increased cost and decreased effectiveness, either side, the numerator or the denominator, we can find the item not to be cost effective. And of course, the win-win for society is that we save money and we have a better tool. And I think that's kind of some of the evidence that we see is unfolding here in the area of screening. And of course, generally speaking in medicine, most things are more costly, and we have to weigh those balances between of whether or not we think it's worthwhile. Now, shifting the paradigm to screening, is what we would hope is that early detection leads to improved life expectancy, less costly, less invasive care, less hospitalization, shorter length of stay. We know patients who are less complicated have shorter length of stay. Every day in the hospital is around $1,500 to $5,000 a day. We do know that these patients, if we can keep them asymptomatic, they have more productive lives, and therefore society is more productive. And the question, some of the key questions, does a more productive asymptomatic individual reduce the cost of care in relation to a symptomatic patient? And we know the answer. Symptomatic care is very expensive. I have an abstract in a couple of days showing that lifetime symptomatic care is about $1 million per patient. Despite improvements in cardiovascular mortality, Allen's Bethesda conference really noted that there was a substantial detection gap. And then we know that if we eliminated this disease and associated conditions, we could actually gain around 3 years of life for every patient. So, and the goal would be, one component of cost effectiveness is to look at the upfront test costs. And this is taken straight out of the Bethesda conference. And the goal would be to find a relatively inexpensive yet accurate test. That's by definition a screening test. And so anything kind of, and these are not what you would charge. This is how much it costs to produce one test, because that's the value, or that's the cost to society. So we see some of these tools which have been discussed, and some comparative tools, EBT in there, is not a very expensive test. And this has been reported in about 3 or 4 different papers. CRP is very inexpensive when you consider a lot of other tests that we can provide. So we do have available inexpensive tests. One of the big challenges that we have is we don't have a lot of cost data, so we need to know how much data is induced downstream-wise by the procedure. So it's not just the upfront cost, but it's the induced cost. And in many cases, the induced costs are substantially greater than the initial costs. I've seen upwards of 10 to 100-fold induced costs. Here we have an example from Tracy Callister's data out of Nashville, looking at around a 19-fold induced cost in an intermediate Framingham risk population with calcium screening. So relatively modest, but we need to more clearly define these induced costs in diverse populations. And we also need to know not only procedural costs, but the induced medication costs. We can see, it's interesting, I always kind of think, just kind of anecdotally, that the medication costs would be substantial. And every type of analysis I've looked at, what we see is that when the added medication costs are around 7, 12, 14, 15%, when you add on purely treating for calcium alone, not what they're currently receiving or any changes to therapy. Looking at statin therapy, for example, and this is how we did that. It's also one of the most costly drugs that we can give in cardiovascular medicine in a prevention setting. This would add about 12% of the total cost of care. So a very modest improvement, at least in terms of my experience in doing some of these analyses. And therefore, we can actually calculate total costs, the number of events that we could actually look at. Now remember I said that the U.S. Public Health Service looks at cost per life year saved. I particularly like to look at the cost to identify major adverse events. And we can see in a low-risk population, a Framingham risk score under the 6%, about $73,000 to identify cardiac death or myocardial infarction. But in an intermediate risk patient population, we can see actually a more favorable economic profile of about $37,000 per life year saved. I can put it in a stringent model. One of the challenges of putting it in a stringent model of cost per life year saved is that I have to extrapolate to life years. Most of these patients in their 50s, that would require me, therefore, to extrapolate almost 30 years into their life. For me to do extrapolations, I can do it mathematically, but it may or may not be relevant to somebody who is truly 78 years old. But there are these principles of high-risk cost-effectiveness models which have had a lot of experience in the literature, and they would state that the overall clinical effectiveness of a therapy and the clinical effectiveness of a procedure is increased in higher risk populations. We can use that principle. In other words, the risk reduction is greater in this intermediate risk group than it is in a low risk group. Clinical effectiveness and cost effectiveness do parallel one another for those of you clinicians. So if we focus on this intermediate risk group, we can actually see, if you look at cost per life year saved, you can get values well in excess of $50,000 per life year saved. Interestingly enough, this was amazing to me. I just purely did this as a mathematical exercise, extrapolating this. Right at about a 1% risk, or right at that intermediate risk, Framingham risk, 1% risk per year of cardiac death or infarction, we went below the $50,000 per life year saved. So this kind of is very supportive and integrated with the published literature, and I think that shows that this intermediate risk category can not only be clinically effective but cost effective. I think this is where we stop. Alan's going to talk about some of his experience in cost effectiveness, but one of the challenges is we don't have a lot of data in these areas. There are key leverage points in determining cost effectiveness. We have to have a moderately priced test, which we do. We have to minimize the induced cost. We have to have effective tests which stratify. It's helpful to have very long-term outcome data so that we don't have to extrapolate well into the decades beyond that. And of course, one of the challenges is we have to have a test comparator. If we compare to no testing, all of you would agree that left untreated, cost of symptomatic care is substantial and delayed, and it could be a decreased societal productivity, could be substantial in patients presenting, obviously, with sudden cardiac death, early retirement perhaps for those patients, a lost productivity of those with non-fatal infarction. These are substantial burdens to society versus a Framingham risk. I'm not going to spend, because I know Alan's going to talk about that. And of course, but these are the real keys when we talk about introducing national screening. We need to know better than we're doing nothing at all or versus a Framingham risk. And of course, some of the key questions would be which test, but that's the secondary question, second question about which one. And that's my last slide, so I'm going to turn it over to Alan.